When I see someone on the street that's acting kind of funny, you know, talking to himself, it makes me nervous and I want to get away from him.
I guess I kind of feel sorry for him. I can't imagine what's going on in his brain.
I can't relate to these type of people. I think they're just trying to make us feel sorry for them so that we can give them some money.
For most individuals, contact with a person who has obvious symptoms of schizophrenia is a disquieting event. Almost everyone can imagine what they would feel like if they were to lose their sight or hearing. But psychosis is different, almost incomprehensible. And often the observer feels alienated from or repulsed by the individual rather than empathetic. Fear may also play a role, for mentally ill individuals are perceived as unpredictable and sometimes dangerous. So the person then not only has a devastating disease, but often does not receive consideration from others. Knowledge of the symptoms of the disease, however, may to some extent help others understand what the person with schizophrenia is experiencing. Psychiatrist E. Fuller Torrey writes, "As we come to understand it, the face of madness slowly changes before us from one of terror to one of sadness. For the sufferer, this is a significant change." Understanding the symptoms is also important to helpers. It assists them in recognizing when they must modify their approach to help those with schizophrenia more effectively. The characteristic symptoms of schizophrenia are divided into two broad categories: positive, which can be described as excesses, and negative, which are behaviors that are missing. Individuals who have a predominance of positive symptoms have fewer structural abnormalities in the brain, respond better to most antipsychotic medications, and have a better prognosis overall than do clients with a predominance of negative symptoms. One prominent positive symptom is a delusion or false belief. This is an unshakable conviction that is not shared by anyone else in the person's religious or cultural group. Many experts believe that pathological changes in the brain, which cause the person to have overacuteness of the senses and an inability to integrate and filter out incoming stimuli, contribute to the delusions that are commonly seen in schizophrenia. One type of delusion is ideas of reference, where everything has a special and highly personalized meaning. For example, advertising messages are specifically aimed at her rather than at the general public. Another delusion is that of persecution, in which the individual believes that there is some plot or malevolent action against him by a person or group. Jean Sanchez, an advocate for persons with mental illness and whose son has schizophrenia, discusses this.
When he walked in the house, he looked like a different person. His posture was different, his grooming was different, and he was afraid. There was actually fear in his eyes, and we had no idea what it was. No idea, but we knew something was terribly wrong. He isolated himself in his bedroom. He stayed up all night pacing. He carried his stick around and looked through the drapes because he was afraid he was being attacked. Someone was going to attack him.
Very often, delusions of persecution are somewhat fragmented, making it hard to follow the plot and understand the characters.
They've been following me. They're trying to kill me.
Who's they? What are you talking about?
They know my every move.
There's nobody following you.
Using logic or reasoning to dispel delusional thinking is usually futile.
There's nobody out there. Just take it easy, pal.
He's in on it. He's one of them.
Because an occasional client with a delusion of persecution can be frightened enough to strike preemptively to protect himself, individuals with this can be dangerous. Other common delusions include those of grandeur, in which the person believes he is a famous or powerful person.
I have the answer right here in my hat. It says free. And you know, I saved this whole place one time around.
thought insertion, where the person believes that thoughts are being put into her mind by an outside force.
Sometimes Jesse's putting thoughts in my mind.
Who is Jesse?
Jesse, I met him over at the thrift store.
Is he your boyfriend?
He's just a friend, but he tries to use my mind for his sexual notices and thoughts.
How does he do that?
I don't know, but I use this to protect it, and it can't get in. Can't get in.
Thought broadcasting, in which the individual believes her ideas or emotions are transmitted without any action on her part.
Come on, honey, you've been in here all day.
I know everybody knows my nasty thoughts. That's why they're so mean to me.
And thought withdrawal.
You know, the guy on the TV, man, he is taking my thoughts, you know? He's taking my thoughts. He is stealing my thoughts from me.
Some believe that delusions are the individual's way of explaining that some force is altering his brain, changing his thoughts and feelings. When evaluating a person suspected of having delusions, the assessor must consider the beliefs within the context of the person's culture and particular situation. A person who is fearful of others finding out where he lives may in fact not be suffering from a persecutory delusion, but may, for example, be concerned about a bill collector or a disgruntled acquaintance. On the other hand, the person may truly be having such a delusion. It is therefore important to interview him at some length, employing deeper, more probing questions that may make the delusion apparent. Hallucinations are another common positive symptom. With this, the individual has sensory experiences without any stimuli from the environment. The usual hallucination is auditory. Those that are visual or involving taste, touch, or smell are less common. The auditory hallucination may be a single voice, often keeping a running commentary on the person's behavior, a chorus, or two people in conversation. In general, the messages are unpleasant, often castigating and name-calling.
Nasty thoughts.
Nasty thoughts.
You're a terrible person.
Sometimes, a person suffering from auditory hallucinations will not discuss them. Their presence may be suspected if the person covers her ears in an attempt to block out the sound, talks back to the voices, displays inappropriate laughing or smiling, moves her head or lips as if responding, or has changes in expression that do not seem to be related to what is going on around her. She may also have difficulty attending and following a conversation. It is important to determine if the person is having command hallucinations, in which she is told to do something. If the command is potentially destructive, care must be taken to prevent the individual from hurting herself or others. Kathy Penny discusses the hallucinations she experienced when acutely ill.
I'd keep hearing voices telling me to kill myself. I couldn't get rid of it. And then when I started hearing voices to kill my mother and my sister, you know, that's when I thought, oh my God. But there's always a part of you that you just don't want to admit that that's going on.
When responding to individuals who express either delusions or hallucinations, it is most effective to acknowledge them and express the reality of the situation in a matter-of-fact manner.
I shot Richard Nixon.
I know you think you shot Richard Nixon, but I'm not so sure. I think he died from a stroke.
Being sarcastic or agreeing with a person's outrageous statement is not helpful and may serve to confuse the person even more. Sometimes, a person's comment is an attempt to test reality. In this case, it is helpful to simply state what the reality is.
Are the Russians after me?
No, Trevor, the Russians are not after you.
If a delusion is strongly held, however, any discussion or reality orientation is not helpful. It is helpful to assist the person to use distraction to counter delusions and hallucinations.
No! Patricia, take your headphones off. Now, I want you to help Isabel hang up the clothes in the bag. Take out an article.
Hang it up on the rack there.
Individuals who have had the disease for some time often have developed methods to counter the symptoms. For example, humming or whistling. Also, it is helpful to offer assistance to the person to deal with the consequences of his delusions or hallucinations.
Frank, how can I help you feel safe?
Many authorities recommend that the person be counseled regarding the appropriateness of discussing delusions or hallucinations in public or with non-family members. This prevents undue attention being focused on the individual and causing embarrassment. Such counseling is best done by peers, but can also be done in education sessions.
Keep it to yourself. You're talking nonsense again. People get scared when they hear you talking that way. Keep it to yourself.
A noticeable increase in delusions and hallucinations should be cause for concern, as it may indicate that the person is not taking prescribed medication. Such an individual is more likely than others to engage in violent behavior, especially if illicit drug or alcohol use is also present. Helpers need to take precautions to protect the person and themselves from harm. A third positive symptom is disordered thinking. Because of the disease, the brain is unable to sort stimuli, interpret them, and respond normally. An impairment in logic is common. This may account for some of the difficulties individuals have with activities of daily living, such as managing money, obtaining food, and using public transportation. Because of the disordered thinking, a wide variety of bizarre behavior and communication results. The person may have difficulty comprehending what others say. He hears the words, but cannot put them together in a meaningful way.
We'll provide your transportation to and from the shelter.
Group or activity.
After we usually start in with some kind of activity. There are recreational depression, there are groups for depression, like arts and crafts, and then we do outdoor activities. Like we're open sometimes we go to some of the things that we do here at the center. They go to parks and museums.
Also, he frequently cannot interpret visual stimuli. For example, when looking at a clock, he cannot perceive it as a whole, but instead focuses on the individual parts, the case, the numbers, the second hand, etc. Sometimes the individual cannot put visual and auditory stimuli together. This makes it extremely difficult to comprehend television programs or movies or converse with others. The ability to respond in a meaningful way is also affected. Normal, everyday verbal exchanges are automatic, unconscious, smooth-flowing, and stay on the topic. This ability is lost in individuals with schizophrenia when they are not stabilized on medication and are becoming more psychotic. Frequently, then, responses are emotionally inappropriate.
Heather, I've got something really sad to tell you. Artie's dog got hit by a car this morning and they had to put him to sleep.
Chickens run so fast.
What?
A person communicating with someone with disordered thinking may encounter incoherence, as thoughts and images are fragmented, jumbled, and disconnected.
Roger, how you doing?
See those vibrations in those wires are killing me, man. It's radiation.
You hungry?
I got a FM weld that the CIA put right here, and I got a medicine bullet in my arm.
Have a sandwich. Need something to eat. It's good.
Yeah, well, they live in wheat.
When there is a vague connection between the images and thoughts, the term loose associations is used to describe the speech.
Time makes its own happenings. That's an idea I think about a lot. Time makes its own happenings. People don't take hours, minutes, seconds seriously. That's something I take seriously.
Another aspect of disordered thinking is concreteness. The person is unable to think abstractly.
Patricia, have you ever heard the phrase, people in glass houses should not throw stones?
I think I've heard it several times.
What does that mean to you?
people shouldn't throw rocks at windows.
Watch the birdie.
A person who interacts with an individual with disordered thinking may find herself perplexed by the conversation.
He didn't want to stop at the park, and no one would stop at the park.
I must not be paying enough attention. I can't follow him. What does he mean?
And she expends more effort, but still does not obtain any more relevant information. When trying to convey a message to such a person, it is important to speak simply and slowly, just a single concrete thought or command at a time. A long discourse with a lot of abstract ideas will be impossible for the person to follow.
Raymond, I need you to call your mother. She needs to come in here today and sign some papers. It's very important that she does it today.
Planning ahead is important, as being indecisive or giving the person a number of options often adds to his confusion. Care should also be taken with the use of touch. Although it is useful in many therapeutic interactions, it may be misinterpreted by the individual who is not thinking clearly or who has delusions of persecution. Often, he will require more space than usual between himself and another to feel comfortable. To review, positive symptoms of schizophrenia include delusions or false beliefs, such as ideas of reference, delusions of persecution or grandeur, and thought insertion, thought withdrawal, and thought broadcasting. Positive symptoms also include hallucinations or unusual sensory experiences, with auditory being most common, disordered thinking with problems, such as difficulty comprehending, interpreting, and responding to others appropriately, concrete thinking, and impaired logic. Negative symptoms of schizophrenia, behaviors that are missing, are those that the person should have, but does not. One such symptom is apathy, or as it is sometimes called, avolition. The person has a lack of drive. He appears to seek or want nothing. Work, school, and tasks are neglected. The person is often content to just sit. Liz Davis, whose son has schizophrenia, discusses this.
He was at UCLA, and it was his second year of college. His first report was a very, very low one, and he was put on probation. And he didn't spend as much time with his friends. He started spending a lot of time in his room. Then he started cutting classes, was not going to school. He took a ski trip at the end of, well, at the beginning of the second quarter, and then he didn't go back to school. He just left school. Started spending more time alone, lying on the couch in the daytime, spending time in his room. Not, when you talk with him, it seemed to take a long time for him to respond to your questions.
This lack of energy often affects most areas of life. Grooming usually suffers. Teeth are unbrushed. Hair and body unwashed. Clothes are dirty and rumpled. There is frequently a failure to take care of personal belongings or to maintain a clean and safe living area. Social withdrawal, another commonly seen symptom, may occur for a variety of reasons, such as to slow down incoming stimuli or to escape from frightening thoughts. If the person is terribly overwhelmed or frightened, he may temporarily need to be alone. However, because the consequences of isolation can also be detrimental, many authorities believe that the person should be gently urged to gradually participate in activities with others.
Some of us are going to play ping pong. Wouldn't you like to join us?
The symptom alogia, although defined in the dictionary as the inability to speak, here refers to a reduction in the amount or content of speech. Often the affected person will be slow to respond or will not respond at all.
It was very different because you'd ask him a question, you're speaking with him, and it was as though he was not listening to you, even though it seemed like he was listening. it would take him a while before he would respond to what you were saying. This seems so strange. And since then, since I've read about it, I realized that he probably was hallucinating. He was probably hearing sounds in his head and thinking about what was going on inside himself, and therefore it took him a long time to filter all of that so that he could listen to me and understand what I was asking him.
Another negative symptom is changes in emotions. The person may have blunted emotions. The term flat affect is sometimes used to describe the person's outward expression. He responds to almost any stimulus with a toneless, flat voice and an expressionless face.
Oh, my father was killed a year and a half ago, and I was just talking to my mom about it, and she was upset about it.
This non-expression of emotions, however, does not mean that the person does not have feelings. In addition, individuals with negative symptoms of schizophrenia may have anhedonia, that is, an inability to experience any kind of pleasure from any type of activity. It is sometimes difficult for clinicians to distinguish between negative symptoms and depression. Such a distinction is important, however, because different therapeutic interventions are used for each. To review then, negative symptoms of schizophrenia include avolition or apathy, social withdrawal, alogia or deficit speech, changes in emotion such as flat affect, and anhedonia, an inability to experience pleasure. A variety of bizarre behavior is sometimes seen in individuals with schizophrenia and is usually a response to their problems with sensory input and disordered thinking. Some engage in posturing, that is, make strange gestures or contort their bodies. If questioned, the person may give a reason for this behavior which is logical to him, but not to others. A challenge for healthcare personnel is to differentiate the bizarre behavior due to schizophrenia from that due to side effects of psychotropic drugs. Often, the bizarre behavior due to drug side effects is quite characteristic and recognizable by experienced personnel. Another type of bizarre behavior is ritualistic behavior. The person may feel she has to repeat a movement a certain way. Ritualistic behavior may be due to schizophrenia or to a coexisting problem, such as obsessive-compulsive disorder. Catatonia is an extreme example of bizarre behavior. It is less prevalent today than early in the century, possibly as a result of treatment with psychotropic drugs. In catatonia, the individual may remain in one position for an extended period of time, or may show overactivity, be wildly excited, and expend a great deal of energy. Relying exclusively on current symptoms to make a diagnosis of schizophrenia is difficult because all of the symptoms can be seen in other mental illnesses. Rather, diagnosis is based on the pattern of symptoms as they occur over the course of the person's life. Gail Green discusses what her life was like during the time she was untreated.
I've been schizophrenic since I was 14 years old, but earlier when I was about 12, I knew something was wrong. Voices were beginning to start, but it didn't bring out until I was 14, till I tried to jump off the second-story building of our family home because the voices told me to kill myself. And then I ended up being at the state hospital for about 6 months. And then it was diagnosed I was schizophrenic. And then, they started me on medication, and gradually, it didn't really work that well. I mean, it kept the voices down very little. The voices are like, for me, it's like they never go away. I don't know if anybody has been to a radio station and it got crossed between me 4 or 5 different stations. Well, magnify that about 10 different times. It's like, that's all what's in your head, my head that is. And it just like, I don't know how to describe it. It's very miserable for me at the time. And the best way for me to describe it, when I try to commit suicide, which I have done almost 32 times, I'm trying to silence the voices, and which, unfortunately, I made it back, and which I thank God for. And the medication I'm on now is Colzerol, and I have no voices whatsoever. Also don't have any more night terrors. Night terrors, I can wake up 6 times a night, cold sweat, shaking like a leaf. It's almost like scary. You don't want to go to sleep. And the paranoia that I have is, like, I can get on a city bus, and everybody, I get so paranoid. I have to get off the bus. It can be in the middle of nowhere because I think people are going to talk about me or hurt me. It's like, now with this medication in my Colzerol, it doesn't happen anymore. I can get on a bus. I can sit in the back, or I can sit with a bunch of people that I don't know. And usually, before the medication years ago, I would have to be the last person to leave because I figure if I leave, they're going to talk about me. Well, since I'm on Colzerol, it doesn't happen that way anymore. And the other thing in the old days is that I'm walking down the street, I feel like I had X-ray hearing. Just people across the street and I think talking about me. It's been very miserable being schizophrenic.
The Diagnostic and Statistical Manual of Mental Disorders, 4th edition, the DSM-4, has criteria for helping professionals determine the presence of various psychiatric illnesses. One criterion for diagnosing schizophrenia is that the person must have an active phase as defined by the presence of 2 of the following symptoms, each present for a significant portion of time during a 1-month period. However, because some symptoms, such as auditory hallucinations, are very specific to schizophrenia, only one symptom may be required. A second criterion is that the person should also have difficulties in 1 or more major areas, such as school, work, interpersonal relationships, or self-care for a significant period of time since the onset of the symptoms. This social or occupational dysfunction should be markedly below the level achieved prior to the onset. A third and final criterion is that the duration of the abnormal behavior be at least 6 months. Within this time, at least 1 month of the symptoms characteristic of the active phase should be present. The course of the disease varies. A few individuals seem to recover fully with no remaining symptoms. Most individuals, however, are left with residual disabilities, which vary in intensity. Factors associated with a good prognosis include responding well to new psychotropic medicines and the availability and early involvement with psychiatric rehabilitation. Other factors include being female, having a good adjustment before becoming ill, that is, the capacity to succeed at work or school, and the ability to form peer relationships, being older at the onset of the illness, and functioning well between episodes of psychosis. Most individuals have remissions and exacerbations of their symptoms. They get better and worse, yet remain relatively impaired to some extent. It is also common for a person to have positive symptoms, periods when he has negative symptoms, and periods when he has both. The disease does not become progressively worse over a person's lifetime. It often worsens in the early years of the illness as it becomes fully expressed. The illness then remains stable until the late 40s. After age 50, the symptoms become much less severe. Knowledge of the symptoms of schizophrenia, then, is necessary in order to understand the person's behavior and to work more effectively with him. However, helpers must try to look beyond his symptoms and recognize and work with his abilities.